We are going to be moving now to the first panel, and I would like to invite Dr. Ronald Rosenberg and Dr. Marcos Espinal, is he? Good. Here, to the podium. We will be having 4 panels during the plenary sessions this morning, and each will have either 2 or 3 speakers. We will introduce the speakers at the outset, and the 2 or 3 will give their brief remarks. And then, assuming we have time, which we plan to, we will open up the session to questions. If you do have questions, we will ask you to go to the microphones that are located in the aisles of the auditorium, and please give your name first. During the afternoon breakout sessions, there's going to be much more time to give in-depth comments and discussions. But what we would like this morning is for you, if you have questions, ask brief questions so that we can accommodate any points that need to be clarified for the entire group. Our first 2 speakers, what I'm going to do is provide only the title or position of the speakers. You have the more detailed biographical information about all of the speakers available to you, but we want to leave the maximum time for the speakers to be able to provide their content. Our first speaker will be Dr. Ronald Rosenberg, who's Acting Director, Division of Vector-Borne Diseases, National Center for Emerging and Zoonotic Infectious Diseases. And our second speaker will be Dr. Marcos Espinal, Director, Department of Communicable Disease and Health Analysis, Pan American Health Organization. Please join me in welcoming Dr. Rosenberg.
Thank you, Mary. In 2007, there we go. In 2007, there was an outbreak of undifferentiated fever on the island of Yap. Yap is in the Western Pacific. It's a little place. It's less than 100 square kilometers. And at the time, there were fewer than 7,500 people living there. Yap has had periodic dengue epidemics, and so the clinicians are quite familiar with dengue. And this looked like dengue, but it also didn't quite look like dengue. For instance, there was a lot of conjunctivitis, and also many of the people who were tested using dengue IgM kits were negative. CDC was invited to come out and investigate, and what we found was that the cause of the epidemic was Zika virus, and this was a big surprise. These are the characteristics of the epidemic in Yap. And what I would especially call your attention to is that when a randomized household survey was done of more than 550 people, the indications were that almost 75% of the population had been infected with Zika. However, fewer than 20% complained of any symptoms at all, even subjective fever. Now, there are going to be people much more expert than me who will be talking later this morning about the characteristics of the virus, but I do want to point out that Zika virus is a member of the genus Flavivirus, and that these viruses are almost exclusively vector-borne viruses. 1/3 of all of the pathogenic arboviruses, that is, arthropod-borne viruses, belong to this genus. Both ticks and mosquitoes can transmit the virus, the viruses in the genus, but usually not the same virus species. As Dr. Zhao had pointed out, generally, flavivirus infections can be quite mild. Even in some serious diseases like dengue, you have a large proportion of people who have mild symptoms or maybe even subclinical symptoms. However, when you do have the spectrum moving towards severe disease, the flaviviruses tend to fall into two general groups. One are those that are the hemorrhagic viruses that increase capillary permeability. And examples of these, of course, are yellow fever virus and dengue. The second group are the neurotrophic viruses. And there's a group that's characterized by West Nile virus, Japanese encephalitis, and St. Louis encephalitis. I also want to point out at the beginning, contrary to some of the press reports, that Zika virus was not discovered as an incidental finding of a yellow fever study. It was discovered as a deliberate strategy by Rockefeller Foundation scientists after the Second World War that followed the yellow fever studies, ended in 1965 with the purpose of discovering previously unknown arboviruses. And in Uganda alone, they discovered 9 pathogenic arboviruses, including West Nile virus, chikungunya, Sinbis virus, Onyongyong virus, and Zika. I would also like to point out that, and by the way, this is the infamous tower in the Zika Forest, and the Zika Forest is actually just a very narrow band of forest between the Lake Victoria and the Kampala and Tebe Highway. Just weeks before literally weeks before the epidemic in Yap, the full sequence of Zika virus had been published by 2 scientists from Fort Collins, Goro Kuno and Jeff Chang. I said that we were surprised by the epidemic on Yap. And if you follow the chronology of the disease, you'll see why it was that we were surprised. So here's the discovery of Zika virus on the shores of Lake Victoria in 1947. It wasn't until 7 years later that the first it was isolated, proved essentially from the first human case. This was in Nigeria in 1954. During the 60 years between the discovery in 1947 and the epidemic on Yap, there were a total of 14 people for whom there's published evidence that they had been infected with Zika virus. These were throughout Africa and also in Asia, but there were no epidemics. Then in 2007, we have the epidemic in Yap. And then we have a period of about 6 years when the virus essentially disappears in an epidemic form, although it was found here and there. It reemerged with a vengeance in 2013 in French Polynesia and very rapidly spread eastward all the way to Easter Island, and this process took less than 2 years. So it was no surprise, I think, to any of us that it turned up in South America. It essentially was following the same course as chikungunya virus a couple years, really just 1 year earlier. What we didn't anticipate was the possible linkage with how the virus was manifesting itself. So this is essentially what we knew from the Pacific before it appeared in South America, and Dr. Espinal will be talking about the situation in Latin America after me. Essentially it was the same as in Yap. The disease was quite minor. Most people were actually asymptomatic. But there were the first suspicions from French investigators that there was Guillain-Barré syndrome. There's some small clusters, but the information about these is still quite limited. And as has been informally reported, there is also an indication that there might have been a spike in microcephaly cases in a major maternity hospital in French Polynesia in the year after the epidemic swept through. Well, the epidemiology of arboviruses is inseparable from the ecology of the vector. In this case, it's the genus Aedes. Zika doesn't seem to be very particular about which of the many species of Aedes it infects. It was first isolated in Uganda from Aedes africanus up in that tower, so it's an arboreal mosquito. It's been isolated from a number of other Aedes, and in the South Pacific it might be transmitted by mosquitoes like Aedes henslei and Aedes polynesiensis, which are native to the area. But this particular species, Aedes aegypti, is one that concerns us considerably. Aedes aegypti is a highly habituated mosquito. It's one of those pests like cockroaches and the house rat that have evolved over the last 15,000 years to exploit changes in human behavior and human habitation. So essentially it thrives around where people live in very close proximity. This recently published map shows not just where Aedes aegypti has been found, but also where the regions are hospitable to aegypti, and so where we might be able to find it. There's a cognate species, Aedes albopictus, that actually extends considerably farther into the temperate zones, especially in North America and in Europe. This is a very personal list, and the whole purpose of this meeting is to expand and refine a list about some of the things that we need to know, or tools that we need to explore Zika virus. And some of these have already been touched on. First, we know very, very little about the infective course of Zika virus. As you can see, no one was really, even after the epidemics in the South Pacific, terribly concerned until the problems emerged in Latin America. We don't really know what the length of viremia is. We don't know how infective asymptomatics are. We don't really have a very good antibody profile for it. Should it be the cause of birth defects really depends on our having good incidence data and some very basic studies, which, by the way, are underway in Latin America now. Until we have incidence and we have baselines, we do not know what the risk factors are. So we would not know, for instance, if there are confounding or contributing factors, if it were in fact causing GBS or birth defects. We don't know at a very basic level whether the virus has mutated, and that is a cause of this explosive epidemic potential that is only recently shown. We, of course, have to be concerned about the transmission in blood products and in transplantation. We have done this quite successfully for other arboviruses like West Nile virus. But the issue of sexual transmission, especially if it is confirmed that exposure in pregnancy is a factor, is something that we have never faced before with any of the arboviruses. Our diagnostics are really wanting for good serological diagnostics. We can easily diagnose the virus itself by amplifying the RNA, but when people are living in an endemic area for other flaviviruses, especially dengue, getting a positive IgM without doing a PRNT is extremely difficult. And so this is an area on which all the rest of epidemiology depends. We need to do a lot of work on animal reservoirs. It was first isolated from a subhuman primate. We don't know if there are other vertebrates that it can go into and whether or not it is even now in Latin America infecting possible reservoirs. We still have a lot of work to do on the vectors. We don't really know the course of Zika in the mosquito, incubation periods, what have you, or even what the species are that might be transmitting. Finally, I want to point out that Zika and chikungunya did not come out of nowhere. There are about 200 identified arboviruses and another 200 that are possible. Only 90 of these have been incriminated as causes of human disease. And most of those 90, and I put Zika in this category until very recently, are so obscure that they have not really been studied. So regarding that last point about zoonotic arboviruses that come from nowhere, I want to conclude with this photo. This forlorn artifact, which has been abandoned in the Zika Forest, is one of the original mobile labs used by the Rockefeller Foundation, Medical Research Council, and the East African Virus Research Institute during the time that Zika was discovered. And while I'm not terribly interested or moved by symbolism, I do want to say that looking at this photograph, I wonder whether our strategy of investigating these obscure viruses that can emerge suddenly and cause problems that we had never anticipated has over the years lost its wheels as well. Thank you.